Welcome to the workshop, Transplant and CAR T-Cell Therapy for Older Adults, Finding the Balance Between Benefit and Risk. My name is Sue Stewart, and I will be your moderator for this workshop. Before we begin, I'd like to thank Bristol-Myers Squibb, whose support helped make this workshop possible. It's now my pleasure to introduce to you today's speaker, Dr. Amelia Langston. Dr. Langston is a professor and executive vice chair of hematology and medical oncology and the medical director of the Bone Marrow Transplant and Stem Cell Transplant Center at Winship Cancer Institute at Emory University in Atlanta, Georgia. She's been a transplant physician and clinical investigator for over 20 years. Her research focuses on innovative strategies for both autologous and allogeneic stem cell transplantation, with a special interest in preventing and managing graft-versus-host disease. Please join me in welcoming Dr. Langston.
Thank you so much, Susan. It's a pleasure to be here today with you to talk about a topic that I think is very important, both to providers of transplant and cell therapy care, but also to patients and their families, and that is the issue of how do we approach the patient who is an older adult and could potentially benefit from either cell therapy or a transplant. Just today in my inbox and my emails, I received the published results of a survey that I think is particularly timely. It really revolved around geriatric assessments in patients facing the possibility of transplant or cell therapy. It was a survey that was sent out to transplant physicians around the country, and I think the bottom line was transplant physicians have a lot of interest in geriatric assessment, but very limited knowledge and limited use of formal geriatric assessment in practice. But I think there was almost universal agreement that age is just a number. So it's really important that we think a little bit more deeply about how we approach our older patients. I have no financial or other disclosures that are relevant to this presentation. So my objectives today are really to start with a little bit about why age matters when we're thinking about transplant and cell therapy. We'll cover some of the health issues and other factors that affect risk for the older adult. We'll talk about assessments and interventions we can use to reduce risks. And then we'll finish up with some outcomes and how outcomes compare with in older patients with those of our younger folks. Now, why is this an important topic? Well, let's think about the epidemiology of the diseases that we're treating with transplant and cell therapy. And with the exception of Hodgkin's lymphoma and acute lymphoblastic leukemia, these are diseases that occur predominantly in patients in the later decades of life, certainly mostly in patients above the age of 50 and with a substantial proportion of patients above the age of 65. So it really is relevant given that epidemiology. And what we have seen, and these are registry data from the Center for International Bone Marrow and Transplant Research, but these are data that really demonstrate the increasing application of, in this case, autologous transplantation to patients in the older set, so that now over a third of patients undergoing autologous transplants in the United States today are 65 and above, and a reasonable fraction are in the 75-plus year range. This is just the corresponding graph for patients undergoing allogeneic transplants. And as you can see, almost a third of patients getting allo transplants today are 65 and above. So this is a group that we need to look at a little bit differently, but the reasons for this change, I think, are worth thinking about for a minute. So what's changed? Certainly we have better supportive care, better antibiotics, and in general better immune suppressive medicines than we did 10 or 20 years ago. We've also increased the use of reduced intensity chemotherapy regimens for allogeneic transplantation. We've got new and evolving types of adoptive cell therapy, CAR T-cell therapy, and beyond. But 2 points that I think are worth thinking about that are particularly important are advances in cardiovascular medicine and advances in the treatment of solid tumors, which sometimes lead to secondary malignancies that we treat as hematologic oncologists. And in both cases, what we're talking about is patients that would have succumbed to a different sort of disease earlier on are now living, whether it's atherosclerotic cardiac disease or whether it's a solid tumor. We're now more successful in taking care of them, so they're living to get leukemia and lymphoma and other things that we need to manage. So let's start with facts. Fact number 1, stem cell and transplant and adoptive cell therapy are generally our most powerful tools for most blood cancer and marrow immune failure syndromes. And for many diseases, transplant or CAR T-cell therapy offers the best and maybe the only potentially curative option. But transplant and cell therapy are stress tests, and they're clearly also our most dangerous treatments that we use for hematologic malignancies and marrow and immune failure syndromes. We've got infections and sepsis syndrome. We've got all the toxicities of chemotherapy and the medications that have to be taken as part of the transplant process. For CAR T-cell therapy, we've got cytokine release syndrome and neurotoxicity, and I'm sure there are going to be a lot of questions about that. In the allogeneic transplant setting, we've got graft versus host disease, which can lead to a whole other set of complications that we have to deal with. And then we've got the side effects of management of the complications of CAR T and transplant therapy, particularly steroids and other immune suppressive medications that then lead to a whole host of other problems. And then we've got the effects of a prolonged hospital stay. When everything goes great, that's terrific, but when things don't go well and the patient has to stay in the hospital for a more prolonged period of time, that's really harder on our older patients than in somebody who's 25 years old. And so we have to deal with the physical debilitation that goes along with that. So the name of the game really here is resilience. And the Oxford Dictionary defines resilience as the capacity to withstand or to recover quickly from difficulties. And it's really this concept of resilience that I'm going to focus on really for the rest of the time, because I think it really is what separates the patient that is a good candidate for transplant or cell therapy from one that may be where it may not be such a great idea. Now, when we talk about risk and resilience, there are a lot of different dimensions of risk that we have to think about. Certainly at the top of the list, we've got comorbid illnesses that the patient may have that may coexist with their blood cancer or their immune deficit. We've also got frailty, which we're going to spend a little bit of time on in a minute. And frailty is really important, again, because we're talking about something where when there are complications and there is a prolonged hospital stay, the frail patient tends to become more frail, and that can lead to a whole host of other things. We've got the nutritional status of the patient, which becomes very important because we know that during cell therapy and transplant, patients are going to go through a period of nutritional deficit. And so we want them to be in as good a shape going into the transplant and try to maintain their nutrition throughout the process. Then we've got some things that might not be so obvious. There's cognitive impairment of the patient, and it's very clear and has been repeatedly demonstrated that patients who go into transplant with cognitive impairment have less favorable outcomes than those who go in with intact cognition. We've also got another kind of hidden issue, and that is that the older patient is more likely to have an older partner or spouse, and the caregiver age and caregiver fitness becomes very important, particularly if there are physical complications of the process that lead to the person being physically debilitated for a period of time. And then finally, we've got financial stressors that exist for all of our patients, but particularly for our older patients that might be living on a fixed income. We have to think about what the financial burden of doing these things and being away from home is really going to be. So as we start thinking about any patients, but particularly older patients as potential candidates for cell therapy, we look at, again, we make an assessment of their comorbidities, and that's a very formal process I'll show you in a minute. There are a number of ways that we can look at frailty and fitness. And then we also need to think about the medical side of things. Can we make a medical treatment plan that makes sense for that person and that has a reasonable likelihood of success given the tools that we have and the disease status of the person? And then at the end of the day, can we justify what that individual's risk is going to be? Now, we have a well-validated comorbidity index that we use in transplant medicine. We've had it for many years, and it really breaks down different types of medical problems outside of the arena of blood cancer and immune deficiency. And it's a point system that was really derived from, pretty complex statistical analyses. But at the end of the day, what this does is you get points for each of the different things that you have, and then we tally up those points at the end. And as I'll show you, this is very highly predictive of outcome, in particular after allogeneic transplant therapy and also CAR T therapy. We also have another scale called the Karnofsky Performance Status, which again is a very old measure, but it looks at kind of the fitness of the patient in very general everyday terms, from the person that has absolutely no limitations whatsoever all the way down to limitations that may get in the way of being able to kind of do the things that might be needed during the course of a prolonged hospitalization. And what we can see is that both the comorbidity index and the performance status of the patient predict non-relapse mortality. So mortality following allogeneic transplantation that is not due to relapse, but due to complications of the transplant process. And they're also both of these measures are highly predictive of overall survival of the patients when we correct for the disease status and other things. So clearly these are elements that we routinely use in everyday assessment of every patient that we see, not just the older set, but older patients are more likely to have more comorbid conditions, and they're more likely to fall down toward the middle of that performance status measure. So right there we have a little bit of a difference in terms of the average risk based on age. Now, what about measuring fitness and frailty beyond just the very crude Karnofsky score? And there are a variety of different tools that geriatricians use to try to assess this. Certainly we want to look in several dimensions. We want to look at mobility, how and the 3-minute walk test is actually a nice test because anybody can do it. It doesn't take a geriatric specialist, and then you can measure based on how far the person can walk in 3 minutes. It gives you a score that again gives you an idea of the fitness and mobility of the patient. I find the instrumental activities of daily living assessment to be a very useful measure that I can do right in the office the day that I meet the patient. So it's not just about, is this person living independently, but can this person handle using a cell phone, emailing, doing their own shopping, their own cooking, driving the car, managing bills. And that gives you a lot of different dimensions of how the person functions, both cognitively and physically. And then we have cognitive and mental health assessments, and that really typically involves a geriatric assessment, which should be done by a true geriatrician. And, most transplant centers exist within the context of a university health system, so there are geriatric specialists that are available. I think what's not always available is that close partnership with the geriatric team so that you can literally kind of dial them up and say, I've got another person that I need you to see. And then most transplant centers will also have nutritionists on staff that are part of the evaluation process. And for anybody that I think has any nutritional needs, I have my nutritionist actually see the patient pre-transplant so that we make a plan in terms of how we're going to weather the storm of kind of nutritional deficits surrounding the transplant or cell therapy maneuver. Now, there are a number of other things to think about. Again, I've mentioned the age and fitness of the proposed caregiver. That clearly matters because if the patient does become debilitated, is that caregiver really going to be able to pick up the patient off the floor if they fall? Is that person really going to be able to manage medicines and other kinds of things? I think sometimes tolerance of the treatments that led up to the question of cell therapy can tell us something about resilience. So the person that sailed through intensive chemotherapy for leukemia, that person has a much better chance of doing well with the transplant or cell therapy than the person that struggled at every step of the way and spent extra time in the hospital and that sort of thing. I think it's also important for patients and their families to understand what their own goals are and what their own expectations are of undergoing a transplant. Because if your goal is to be alive a year from now, that's very different. The answer may be different than if your goal and expectation is to be alive 5 years or 10 years from now. And then I think it's also important for patients and families to be empowered to ask realistic questions about expectations of both short and long-term outcomes based on that pre-transplant assessment that includes a lot of different dimensions of testing. So how do patients do with these therapies in the real world? And this is a analysis, again, from the Center for International Bone Marrow Transplant Research, looking at patients undergoing autologous transplants for multiple myeloma. And what you can see is that across a range of ages, overall survival after transplant is no different for the younger patient versus the older patient across the spectrum of ages that encompass most myeloma patients. Now, that's not to say that we aren't careful about assessing those older patients, but the fit older patient can certainly do very well with autologous transplantation. Now, these are data looking at allogeneic stem cell transplant versus chemotherapy alone in patients with AML in first remission. And what you can see here is that, and again, this is using registry data on transplant and cooperative group study data on chemotherapy, but really trying to match patients for risk. And what you can see is that while there's a little bit of an early drop-off in terms of survival in patients undergoing transplant due to the toxicities of the transplant itself, at the end of the day, transplant is more effective therapy than chemotherapy alone in this patient population, and that translates into a better overall survival as you look across time beyond that 1 year mark. And this is just a real-world look at CAR T-cell therapy for diffuse large B-cell lymphoma, looking at patients 65 and older versus those under 65. I won't try to convince you that the over 65 set does better, but they certainly do not do worse. And again, these are carefully selected patients, both selected by us and self-selected, but older patients can do very well with these types of aggressive treatments. And these are data on patients with MDS, looking at allogeneic transplantation versus chemotherapy management, conservative management alone. And the take-home message from this study was really that not only do patients that have a donor and undergo transplant do better, but they also reported better quality of life than the patients that did not have a transplant. So I think this is a strong argument for taking a fit patient with high-grade MDS, intermediate or high-grade MDS, to an allogeneic transplant if a donor can be identified. Now, what can we as providers do to improve outcomes? Certainly, we want to optimize the management of known medical conditions before we ever start the process of transplant or cell therapy. We need targeted evaluations by specialists, and certainly geriatrics, cardiology, infectious disease, if the patient has particular things in their history, the nutritionist, and so forth. And careful evaluation and assistance from a social worker, which is part of pre-transplant evaluation at almost every center, looking at support system, looking at transportation, at lodging, and so forth. These are all important elements that need to be really nailed down before we ever get into the transplant or cell therapy episode itself. And then full disclosure. And we, I think, as providers have an obligation to really disclose what the risks are. And, I am not shy about telling a patient and their family if on balance, after evaluating the patient and looking at the whole situation, if I think a transplant or the cell therapy is a bad idea or a particularly risky idea, I'm going to tell folks that rather than just putting them through the paces because they came to the office. Now, what can you do to improve outcomes? And certainly maximizing your physical status before the start of intensive therapy is important, and also fighting not to lose ground during the treatment itself. So when there is time, and I think time is an important element because for some of these situations, particularly for acute leukemia and the like, there may not be much time to do sort of prehab, as we call it, where you have intensive physical therapy and occupational therapy before the treatment begins. But if there is time, it's definitely worthwhile. But keeping the activity going in the hospital and after discharge is really important. And I'm a real taskmaster in that respect. When I'm working in the hospital, the first thing I say when I meet a patient that's come in for their transplant is, I expect you to walk a mile a day while you're in here. And I expect to see you up in a chair with clothes on during the day, and we're going to go to bed at night and have daytime and nighttime straight throughout your time here. What are some of the other things that you can do to improve outcomes? And certainly optimizing your support team of caregivers is important. I find that for patients who have an older spouse or caregiver, that engaging multiple family members and friends is actually helpful, and preferably having at least some parts of your caregiver team be young enough that they can pick you up off the floor if need be. And it's really helpful if you can designate somebody on the team to be the kind of the organizer and information keeper, because a lot of times there's just a lot of information. There can be changes every time you come into the clinic, and having somebody that just keeps track of the medicines and other kinds of things can be very helpful as you go through this process day to day and week to week. And expect that there may be setbacks and changes of plans. You really have to be adaptable, because there is no straight line from point A to point B. There always are going to be little forks in the road. So in conclusion, in my mind, age is just a number. It's really these comorbid conditions, the functional status, mobility, and support that really inform that risk-benefit equation. And in my mind, it's not a question of who should get a transplant or cell therapy, but who shouldn't. And I think when we find a patient that shouldn't, we need to be very transparent about that, and we all need to participate in shared decision-making. And the critical assessment and decision-making has to occur just prior to the proposed treatment. Lots of people come into the office for a consultation, and we never get to the point of actually doing things. But I'm happy to see patients and assess them and not necessarily make a judgment about whether or not they're a candidate for cell therapy or transplant at the time of that first meeting. But at the time of that last meeting, I've got to be convinced that there's a reasonable chance that this can go well. So with that, I'm going to stop, and I think we've got some questions in the chat, and I'll do my best to try to answer those.
Thank you, Dr. Langston. That was an excellent presentation, very comprehensive. And we do have some questions lined up. If you would like to submit a question for Dr. Langston, use the chat box on the left side of your screen, type it in, and we'll get to as many questions as we can. So the first question is from a woman who says, I live close to my hospital. Is it okay to do CAR T-cell therapy as an outpatient?
That's a great question, and different centers handle this differently, but I think in general, if you live within 20 or 30 minutes of the transplant center, and if your transplant center has the infrastructure to manage CAR T-cell patients as an outpatient, then it's perfectly safe, and that's really been demonstrated time and time again. But when I say infrastructure to do that, what I mean is there needs to be a place other than the main hospital emergency room that you could go, or there needs to be a very direct way that you can contact the treatment team day or night, because the complications of CAR T-cell therapy, when they occur, they are an emergency, and patients need to be assessed in real time, not take 2 aspirin and call in the morning sort of thing.
All right, thank you. The next question is a little detailed. It says, I'm 74 years old. I was diagnosed with AITL, which is a type of lymphoma. I did an autologous stem cell transplant in 2024, then relapsed in 5 months, did a clinical trial with CAR T cells for lymphoma, and did a T-cell transplant in 125. It's been suggested that I do an allogeneic transplant while in remission. My major problem is that Medicare says it's not a covered diagnosis. Have you seen Medicare cover allotransplant for lymphoma? I have no other comorbid diseases.
Yes, there was a determination a while ago that Medicare can cover allogeneic transplants for lymphoma. There are certain hoops that we have to jump through in terms of making sure that patients are registered, but yes, Medicare has made a determination to cover that.
All right, thank you. Next question, is there a difference in outcome between people who have been fit for many years versus someone who just became fit before going into transplant or CAR-T?
You know, that's a great question, and I don't think I have an evidence-based answer for that, but I think that the fitness of the patient at the time that they're coming to CAR-T or transplant therapy is probably the most critical element. And I've certainly seen patients go both ways, where they kind of got fit later in life and did very well. I've seen patients that were fit all of their lives that had a really rough time. So I don't know that that's been really critically studied.
Okay, next question. Does baseline neurocognitive deficit impact the risk of ICANS, late neurotoxicity, after CAR T-cell therapy?
That's a great question, and we know that, I'll tell you what we know. We know that it is harder to assess ICANS in someone who has baseline neurocognitive deficits, because the way that we assess things is by doing repeated testing, and so it's hard if a person at baseline has some degree of dementia to assess how much is hospital delirium, how much is the baseline dementia, and how much is ICANS. We also know that blow for blow, older patients tend to, just in general, whether they have neurocognitive deficits or not, have a little bit of a higher risk of ICANS than younger patients. And we know that people that have a higher disease burden have a higher risk of both CRS and ICANS.
All righty. The next question. Do you find immune reconstitution is slower or less likely to fully recover after CAR T-cell therapy in older patients?
Well, that depends a little bit on what we mean by immune reconstitution. So for most CAR T-cell products that we use commercially, one of the major issues that we see is that we essentially ablate the B-cell compartment of the immune system. And that deficit may or may not ever come back. That's not so much an age-related thing as it is associated with different incidents in different products. But the other aspects of the immune reconstitution and count recovery as well are a different thing and more unpredictable. And certainly the bone marrow function and immune function of a person in their 60s or 70s is different and is less robust than a person in the younger decades of life. And so we would expect that immune reconstitution in those dimensions might be a little bit less robust and less rapid.
Interesting. All right, this next person wants to know, how old is the oldest patient you've treated with CAR-T?
Probably 81 or 82.
Okay. This person wants to know, does left temporal lobe seizure disorder that's under control with meds pose a danger for CAR T-cell therapy?
We know that seizures are a known complication of ICANS. Everybody who gets CAR-T therapy gets anti-epileptic medicines. I would say it may not be an absolute contraindication, but I would be very, very, I would be a little leery of that, and I would certainly be working closely with a neurologist in terms of optimizing the management of anti-epileptics if such a person were going to go to CAR-T. And we kind of know a little bit more than what the answer I've just said, because we do CAR-T on occasion in patients with primary CNS lymphomas or in patients with lymphomas who have had CNS involvement in the past. And by and large, the risks associated with that, while they may be slightly more likely to get ICANS, generally the outcomes have not been different than people that had other forms of lymphoma. So I think you'd want your neurologist to be really plugged into the situation and to kind of give the thumbs up.
Okay. This next person wants to know if you could give some examples of the kinds of cognitive problems that you see after CAR T-cell therapy and how long it takes for them to resolve if they do.
So the cognitive problems associated with ICANS range from a little bit of difficulty with word finding all the way to deep coma. And kind of everything in between. We can see seizures, we can see times when patients, while they are not unresponsive, they may not be verbally responsive. We also, and one of the hard things is telling the difference between some of the more subtle neurotoxicities that are associated with the CAR T-cell product versus the kind of delirium that occurs most often in older people just because they're in the hospital. And, you know, we kind of, we refer to this, it usually happens at night, and actually the sort of name that we have for it in sort of doctor slang is sundowning. And it's actually very, very common in older patients that have to be in the hospital for any length of time. And so, but that's not necessarily neurotoxicity caused by CAR-T.
All right.
I'm sorry, they asked about how long it takes for neurotoxicity to evolve, and that is highly variable. There are people who get one dose of steroids and the neurotoxicity resolves, and there are other people who can have ongoing neurologic deficits for periods of a month or more. And there are some patients that occasionally do not return to their baseline, their pre-CAR-T baseline in terms of cognitive and neurologic function. So it is a serious problem.
Okay, well understood. All right, the next person wants to know whether it's possible to get CAR T-cell therapy if you relapse after an allogeneic stem cell transplant for CLL and have chronic GVHD.
Good question. So CAR T-cell therapy in principle can be given after an allogeneic transplant. I think in the experience, most of the experience that exists has been in the context of either acute lymphocytic leukemia or diffuse large B-cell lymphoma. It is generally less effective in the post-allogeneic transplant setting. For a patient with chronic graft versus host disease who is presumably actively on significant immune suppressive medicines, it's probably ill-advised because you're probably not going to get a very healthy T-cell product that in terms of the manufacturing itself, and it may or may not exacerbate, the CAR-T process itself and the cytokine storm that it creates may stir graft versus host disease on even more. Okay. But in principle, it can be done. It's a question of how effective it's likely to be and what the outcomes are going to be.
All right. So this person wonders what the average remission time after CAR T-cell therapy for multiple myeloma is for someone in their late 60s.
Well, that depends on a lot of things. So, as with many new therapies, the first patients that with myeloma that were treated with CAR T-cell therapy had very, very advanced disease. They might have been through 9 or 10 or more lines of therapy before CAR T was given. And as you might imagine, for that group of patients, while CAR T could create remissions in the majority, it's also the case that the vast majority of those patients eventually relapse, and typically relapse within a year or so. But now we've moved CAR T-cell therapy in myeloma to much earlier in the course of the disease. And what that means is that, in essence, we're treating a different disease, but we're also taking the T cells at a time when they're not so beaten up. And so the T cells are more resilient that we're using for the manufacturing process. And so the outcomes are much more hopeful today. And, this is something that's under active study, but the hope is that if we move CAR T-cell therapy into, second and third line treatment, that there would be the possibility of long-term cure.
All right, that's hopeful. All right, this person wants to know, do you need to take all the vaccines all over again after CAR T-cell therapy, like baby vaccines, pneumonia, shingles, if you had them before CAR T?
So typically, we will revaccinate people after both transplant and CAR T-cell therapy. I think what is still a question mark is, particularly for B-cell and plasma cell-directed CAR T-cell therapy, is when should we do that? Because when we do a transplant, the antibody-producing cells come back reasonably quickly, so we usually start post-transplant immunizations or the baby shots at about 6 to 9 months after the transplant. And for some vaccines like COVID, we actually do it even earlier. We recommend people and have good data that COVID vaccine is effective 100 days after transplant. But we have a lot less data about CAR T and about what the optimal timing is. But generally, we'll do it at about the 1 year mark. And if there's question, we may check titers to see if the person has mounted an immune response. What we do get very nervous about, though, is if someone has continued B-cell aplasia, meaning that they have not recovered their B cells, we generally take a dim view of them getting any kind of a live vaccine, like MMR. And this is obviously a very timely topic right now, with everybody coming in asking if they should go and get MMR. But we generally do not want patients to get a live vaccine like that until and unless they have very good immune recovery because of the danger that they get sick from the vaccine. The worst danger, if you get the flu vaccine or pneumococcal vaccine or something, the biggest danger of getting it at the wrong time is that it just doesn't work, but it's not going to make you sick.
All right. This person wants to know a little bit more about what's involved in being a family caregiver for a CAR T patient. Could you describe in a little more detail what someone would be expected to do? Will they need to take off work? Do they truly need to be there 24/7? And what are they doing when they're there 24/7?
Well, I will go back to the question that was asked earlier about outpatient CAR T. So the responsibilities of the caregiver depend a little bit on whether the CAR-T process is happening entirely in the outpatient setting or whether there's a hospital period of time. But I will, I'll just describe what the caregiver has to do for the period of time that the patient is an outpatient. Yes, you do need to be with the person 24/7. Patients who have had CAR-T are not able to drive for at least a month after they get the CAR-T, regardless of whether they, are having neurologic problems or not. But we ask caregivers to be available and present 24/7 because these complications can occur really at any time of the day or night. We ask that the caregiver be the organizer of the medicines, particularly during the early phase, because of the possibility that the patient might get mixed up and might not be taking the right medicines throughout things. And just simple, the things that you're doing to care for that person, maybe, helping with meals and, again, being a witness at clinic visits, which if you're going to do during the outpatient phase, you're going to be coming in frequently for assessments. And that caregiver has to be astute enough to recognize something is wrong. You got to be able to take somebody's temperature. You've got to be able to make your own kind of assessment of, is this person off mentally? Do I need to call somebody about that?
Well, speaking of food, are there any restrictions on the kind of food, people can eat after CAR T-cell therapy, similar to some of the restrictions that are imposed after an allogeneic transplant?
So I think most centers today follow what we would call a food safety diet, meaning that you're not eating things that would be of obvious danger, like raw meats, raw fish, unpasteurized dairy, moldy cheeses, things like that. But you can eat vegetables, you could eat raw vegetables and salads as long as they're clean. We ask patients, during the time that they're neutropenic, maybe not to go to the salad bar because you don't know, you haven't witnessed how that material was really handled. But in terms of saying you can't eat this food or that food, other than in unpasteurized dairy and raw meats and things, we don't really have big restrictions.
All right. Here's a question. What is the incidence of ICANS in the older myeloma patient receiving CAR-T?
So that's a hard question because we have several different myeloma products and they have different properties and we prescribe them sometimes in different patient populations. But I think in general, if we include any degree of ICANS, we're probably talking about something between a 15 and a 30% risk of significant ICANS that we need to intervene with.
All right. This question is from a woman who has lupus, and she said, regardless of age, if a person has an autoimmune disorder such as lupus, are they still able to undergo CAR T-cell treatment?
So, autoimmune disorders come in a number of, different varieties and severities. I think in general, if a patient has autoimmune disorder that is requiring ongoing immune suppression, we would probably be very nervous about doing CAR-T. If, on the other hand, it's a patient that has had something in the past and it's been controlled and has sort of immunologically burned out, then it may be a different circumstance. But again, that's a situation where we would consult with the person's rheumatologist and make a plan together, using kind of shared decision making.
All right, we have a couple more questions. If anyone has questions, please submit them now so that we can get to them before the workshop ends. The next question is from a woman who wonders, how do you get a geriatric assessment? She's never heard of this at her cancer center.
So generally, a geriatric assessment, again, is something that can be done within the context of the pre-transplant evaluation by referral by the transplant physician. If you want a geriatric assessment, for some other reason or as part of your own sort of process of thinking about whether or not this type of therapy might be for you, then your primary care doctor can refer you to a geriatrician. But generally, for those more detailed kinds of assessments and cognitive assessments and things, that's best done by a true geriatric specialist.
Okay. And again, I think you may have addressed this, but this woman wants to know what percentage of people who undergo CAR-T actually develop neurotoxicity.
Again, it is very, very dependent upon the product that is given and the indication and the disease burden going into CAR-T. In some circumstances with some products, for some patients, the risk may be 50%. For other patients that go in with well-controlled disease, with some of the less neurotoxic product, the risk may be, 10% or so. But there's always a risk. Every single product carries that risk.
All right, and we had a question about going to CAR-T after an allogeneic transplant. What about the reverse? If you go to CAR-T cell therapy and you relapse, can you then get an allogeneic transplant if you didn't have one before?
Yes, and certainly this is a question that we come up against very frequently, in particular with acute lymphocytic leukemia. We oftentimes ask the question, particularly in adults, is CAR-T likely to be curative for that disease by itself? And we will sometimes actually do a preemptive allogeneic transplant. So we get the patient in remission with the CAR-T and then go on to an allogeneic transplant. In the area of lymphoma, we certainly consider patients who have failed CAR-T as potential candidates for allogeneic transplant. I saw a man yesterday that was in that exact circumstance who had gotten back into remission using something after the CAR-T and looked like a great candidate for an allogeneic transplant. For multiple myeloma, not so much, because in general, I think allogeneic transplantation for myeloma does not have a major role.
All right, so speaking of remission, how many people do relapse after multiple myeloma, CAR-T cell therapy, or CAR-T cell therapy for lymphoma?
So that's a bit of a hard question to answer. So I'll start with lymphoma because that's a little bit easier. But so the most common indication for CAR-T cell therapy in the lymphoma arena is diffuse large B-cell lymphoma. That was the first type of lymphoma for which CAR-T was approved, and among about 30 to 40% of patients will achieve a complete remission with CAR-T cell therapy, and in the range of probably about 75% of those patients that achieve a complete remission will be cured.
Okay.
That is not the case for some of the low-grade lymphomas like follicular lymphoma and chronic lymphocytic leukemia. The response rates are lower, and the relapse rates are higher. So that there is reason to question, whether or not CAR T in and of itself is likely to be curative for many of those patients. Clearly, there are some that are cured, but it may not be the majority of patients that respond being cured. With myeloma, again, I think we already talked about this, but the majority of patients that have had 9 or 10 prior therapies who get a CAR T will eventually relapse. But for patients who are transplant or who get CAR T earlier on in the course of the disease, we're still learning about how durable those responses are going to be, but clearly they are more durable than when the patient is transplanted later on in the course, when their T cells are a lot more beaten up and maybe not as effective as killers as they would have been earlier on.
All right, we have 2 more questions that we'll try to squeeze in quickly before the end of the workshop. The first is there an advantage to having CAR T using your own remanufactured cells versus CAR NK using donor remanufactured NK cells?
So this actually brings up a whole area that I think people are very excited about in principle, and that is the idea of an off-the-shelf CAR T product. I think we all of us in the field feel that the idea of having to make a personalized autologous CAR T product is not going to be a sustainable model going forward when we start to treat more patients and when we start to treat patients with common diseases. Blood cancers are not that common, but breast cancer and colon cancer and pancreatic cancer are. And so I think we all believe the future is in off-the-shelf products, and NK cell products certainly are one candidate in that respect. But
okay, and then our last. Oh, I'm sorry. Go ahead.
But we're not there, and chimeric antibody receptor NK cells are not ready for prime time yet. They are still in the investigational stage, and I think we haven't yet figured out generally how to create a situation where those cells persist for long enough to be fully effective and certainly to be curative for the diseases that we treat. So that I'm not going to say it's better or worse, but I think it's where we are, we hope that's where we will go in the future toward allogeneic products, whether it's NK cells or gamma delta T cells or T cells that have been manipulated to get rid of their own identities. But right now we don't have that for commercial use.
Okay, then probably our last question. I'm 78 years old. I've been having Vidaza injections and taking Venclexta pills for 2 years. Can I still have a stem cell transplant?
I assume that this person probably has AML, given the medicines that are ongoing, and whether or not that person can have a transplant really is going to depend on all the things we talked about today in terms of fitness, but also it's going to depend upon whether or not the disease is in remission. But there's no reason why just having been on those medicines would preclude being able to do a transplant.
Okay, and then this is our very last question. How does anxiety and depression that's in remission with medication impact CAR T-cell therapy?
So I think that anxiety and depression are incredibly common and a natural reaction to someone having a malignant diagnosis. And I would say that as long as the anxiety and depression is well controlled and actively managed going forward, and the person is supported as need be, it really should not be a barrier to any of the therapies we've talked about today.
Great, good to know. All right, well, we do need to wrap it up, and on behalf of BMT InfoNet, And our partners, I'd like to thank Dr. Langston for a very informative presentation. And I'd also like to thank the audience for the excellent questions that you submitted. Please let BMT InfoNet know if we can be of help in any way.